that they might be more powerful in giving us prognosis, more powerful in helping us monitor your response to therapy, but really the holy grail for, the real excitement is it going to help us figure out which of those treatments, of those 6 or of those 10, or, when we have 20, which ones are the best for you and your tumor. So the take-home points are that biomarkers can be prognostic. They can help us with response, understanding your response to treatment, and or predictive, and that's really the hope. That circulating tumor cells, microRNAs, and circulating tumor DNA are promising new circulating biomarkers that we are actively studying here. And the greatest potential is developing circulating biomarkers with predictive power. That's to say, those that can help us, the medical oncologists, decide which is the best treatment for you, and hopefully to do so in a blood test or some sort of non-invasive manner. And then finally, I just want to say that patients who volunteer to be on our trials, to donate blood and tissue samples and allow us to study their medical records, such as maybe some of you, this is what makes this all possible. So I'll take questions at the end with the panel.
So that's an extraordinarily challenging area, but it's clearly the future of where we need to invest time and resources. So our next speaker is Dr. Bruce Montgomery. He's a professor of medical oncology at the University of Washington and the Hutchinson Center, and he's going to tell you about the active clinical trials that are ongoing, really what's state-of-the-art now and what we may be able to see outcomes, what we should be on the lookout for outcomes in the near future. Bruce?
Thank you all for coming today. This is a real pleasure because I get the chance to try to put together what you heard from all these other researchers, all the basic and really exciting discoveries that have been taking place over the last several years, and talk to you about how we're trying to use these to actually change the way that we treat prostate cancer. So I think one of the things that's worthwhile emphasizing here is that people come to clinical research from very different perspectives. Okay, so some people consider this to be experimental medicine, which I think is certainly one perspective. I think it's important for us to look back at where we were to get a sense of what we've been able to do with the kind of science that you heard about earlier from many of these speakers that just preceded me, and to realize that this is how we make progress. This is how we've come to being in a very different place. So you actually saw a couple of different schematics earlier in the series of talks about where we were in 2004. Okay, this is basically the picture of where prostate cancer therapy was. We had prostatectomy and radiation. There was then PSA progression. People got hormonal therapy, and that was it. Okay, there was nothing else in terms of treatment. So as a result of actually a fair amount of work that took place here with many of the people that you've heard talking earlier, insights into the biology of prostate cancer and how we can better treat that, we came to today, where basically we have 6 different drugs, all of which are brand new since 2004. Many of those drugs are based on science developed here and clinical research that was done here. And so although we consider it on some level, it's research, there's no question, but it's worthwhile emphasizing that this is how we change how we do treatment. We decide if it's safe and whether it works, and so that in the clinic we can say to somebody, this is a medicine that will work for you. We have real numbers that can support that, and without that, it's very difficult for us to actually say this is the right thing to do for you today. And all the things you heard about earlier in these very elegant talks are designed to figure out how to put these things together in a way that really makes sense in the years to come. So I've been given the job of talking about all of our clinical research in essentially 12 minutes. I don't know where Nola is, but I'm sure she's already flagging me down to speed up. But I'm going to really talk very, very briefly about what the phases of clinical research are and try and dispel some of the concerns that a lot of people have about these types of research. So when we talk about clinical research, the vast majority of the time we're talking about an intervention and how that works. And so when we talk about phase 1, there are different types of phase 1 studies. So the knock that phase 1 has is that it's the first time it's been given to humans, so oftentimes it's really trying to figure out, is it safe, and what is the dose of the drug that is safe. In prostate cancer, we actually are lucky because we know enough about the biology of the cancer that we can design drugs that are actually pretty non-toxic, so we know ahead of time that we're not really talking about horrendous side effects. So a phase 1 study for men dealing with prostate cancer is oftentimes far less of a risk for them than it would be for folks who are dealing with a cancer and whom we don't understand the biology in the same way. But the idea here is to establish a safe dose to give people to decide whether it's effective. So phase 2, everybody gets the drug. We know a dose that is likely to be appropriate for those patients, and we're trying to figure out really how well it works for folks who are dealing with prostate cancer at different times in their diagnosis and treatment. And then if we've decided that the drug, in fact, does have promise and has the potential to be better than the standard approach, it goes into what's called phase 3, which is usually a randomized study of the standard treatment versus our new, more experimental therapy, and looking at comparing the effectiveness of that therapy. Now, a lot of folks that I know have a lot of issues with what are called randomized studies, and I certainly understand why, because what usually is involved is saying, well, with essentially a flip of the coin, some people will get a standard approach and some people will get the experimental approach. I think it's worthwhile emphasizing that standard of care in a center of excellence doing clinical research is not the same as the standard of care out there in the general community. I'm not going to knock general practitioners, but in a phase 3 study, everybody who participates is getting a higher level of examination, care, and input from many experts in their area of cancer research. So even in a phase 3 study where some people are getting standard of care, there's actually been a fair amount of data that supports the idea that people who participate in these studies do better, even if they get standard of care compared to standard of care treatment out in the community. And finally, a phase 4 study is making sure that we know how safe a drug is when it's being given to a general population of folks dealing with prostate cancer, because the folks that participate in research studies are highly selected, they're oftentimes incredibly motivated, they know more about their disease than anybody else, and so we need to know how well the drug works in a somewhat less selected population. So rather than trying to cover every area of clinical research that we are doing right now, I'm going to emphasize 3 areas. This clearly does not cover anywhere near all of the work that's going on in our institution, but I'm going to focus on 3 things. So the first is basically hormonal therapy. Now, you've heard multiple people already talk about this. I think it's worthwhile talking about it a little bit more because it is an area where translational research, that is taking the bench research that you already saw discussed earlier into the clinic, has changed the way that we treat prostate cancer and what we're doing to further improve that now. The second is to talk about some new insights about prostate cancer that we think may be relevant in terms of treating more resistant forms of prostate cancer. And finally, to talk about what Dr. Cheng referred to as the new kid on the block, alpha-radon, which is a new form of radiation therapy. So this is a Montgomery adaptation of Dr. Mostagel's schematic, which was much more elegant than mine. But this is supposed to be a prostate cancer cell in the setting in which androgen deprivation has suppressed testosterone levels out in the blood, and shows you that basically these other androgens, including DHEA, are used by the cell to make testosterone and ultimately DHT, which interacts with something called the androgen receptor, and to show you that the cell itself can, in some cases, make its own steroid hormones in order to drive its growth. The other thing that happens, which I think was touched on earlier, is that the tumor cell also increases the amount of the receptor for testosterone as a way of much more effectively using whatever androgen is actually around. So this relatively simplistic idea has actually changed the way that we treat advanced prostate cancer, because we now know that hormone therapy remains an important area of focus. You also saw this schematic, which is a somewhat more generalized idea, that what we do today in terms of standard approaches are to try to suppress hormone production from actually suppressing something called luteinizing hormone from the brain, which turns off testicular androgen production. But today, hormonal therapy really includes this, abiraterone, which turns off adrenal production and production within the cell itself, and enzalutamide, which blocks testosterone binding to its receptor. So that is the picture of hormone therapy today, which is very different than it was, again, 10 years ago. So right now we have these two drugs that are FDA approved, abiraterone, also known as Zytiga, and enzalutamide, otherwise known as Xtandi, and these are basically better forms of hormonal therapy that we've been using for the last 60 years. The issue is that because these drugs have had such an impact on treatment, there are now many, many different attempts to improve on these drugs in order to make treatment even more effective and less toxic. So right now, I would just mention that we have an open study that we're one of the lead sites on, a drug called galeterone, otherwise known as TOCO1, which is a different type of inhibitor of CYP17. It can block the androgen receptor. It can suppress androgen receptor levels. So that drug is now in clinical study here as well as a number of other institutions. There's a drug called VT464, which is essentially a different type of inhibitor, which will not require steroids, we believe, and may be a little bit better than abiraterone in terms of its toxicity profile and the way that it might work. Orteronel is essentially another type of abiraterone, which has some advantages, again, being able to use it without steroids. There's a drug called GTX-758, which is a drug that's being really looked at by Evan Yu, who I think you heard about earlier. It's an estrogen receptor agonist. This is a very unique way of suppressing androgen signaling by increasing the binding proteins that take androgen out of circulation and therefore reducing its effect in prostate cancer. And then something called ARN-509, which is very similar to enzalutamide but has some potential advantages in terms of activity. So those are single drugs. And then what we're doing now is, I think everybody is excited about the idea of putting these drugs together in a way that makes sense. We will have a study very soon putting abiraterone together with enzalutamide in men who are undergoing prostatectomy in order to improve their situation coming out of surgery. You heard earlier from Dr. Nelson about the idea of PARP inhibitors. We have an open study now of a PARP inhibitor with abiraterone. And we have an open study of the drug enzalutamide, trying to use that in addition to targeting blood vessels in the tumor. The last thing that you heard from Dr. Mostigel, which I think is something that is really where we're going, although we're not there yet, is this idea. I'm not sure that you can really see this particularly well, but what this is supposed to be right here is a schematic of the androgen receptor, and as she showed you, there are now at least two forms of the receptor in which the part of the receptor where both testosterone and the drugs that we use to block the receptor are gone. And so the idea here is that this part of the receptor is constitutively active. And so where everybody is going, and we are very actively involved, is targeting this part of the receptor. And so there are two drugs, a version of what's called EPI-001 and something called T6, which we hope to have in the clinic within the next year, trying to figure out whether that, in fact, will block these forms of resistance that Dr. Mostigel was talking about. So I haven't seen Nola say anything yet, so I'm going to continue. So the other thing that I think is important is we sometimes have very rare forms of prostate cancer, which we have thought of as relatively unimportant. So these include things like small cell or neuroendocrine carcinoma, squamous cell carcinoma, and something called sarcomatoid. So these were essentially side notes in terms of the treatment of prostate cancer because the standard type is what's called adenocarcinoma. That's the garden variety prostate cancer we deal with all the time. However, over the last, I would say, 2 or 3 years, it's become recognized that this small cell component, or neuroendocrine disease, may make up a significant proportion of resistant prostate cancer. So some people have suggested that up to 25% of the prostate cancer late in the course of the disease may actually have some small cell component driving part of the biology of the disease. So the thing that's relevant here is that small cell cancer does not respond to hormonal therapy, and it basically makes no PSA. So it's very difficult to follow it in terms of its response, and we're pretty sure that our standard treatments are not having an effect. So what we do in the clinic today as a standard of care for small cell cancer is chemotherapy, which I think, we all recognize both the pros and the cons of chemotherapy, clearly more toxic than things like hormonal therapy. And the idea here is that many people have looked now at these small cell cancers, and they've shown that there's something called Aurora kinase, which is upregulated in the cancer. Now, Aurora kinase is involved in what's called normal cell division. So when cells grow and proliferate, they divide, and Aurora kinase is involved in that cell cycle transition into separate cells. If Aurora kinase levels are aberrant, what happens is you get what's called aneuploidy, and you can basically, this is a bad actor, okay? The cancer starts acting more aggressively in a way that is very hard for us to actually target. So the idea is that drugs that target the Aurora kinase, which we think is very relevant in small cell cancer, are now in clinical studies, and we have it open here. We're one of very few sites in the United States that have this drug available. It's oral, it's relatively non-toxic compared to chemotherapy, and that study is ongoing. We don't have a real readout from that study yet, but we are actually very excited about the idea of targeting this disease more aggressively. The other thing that you heard Dr. Nelson talking about before was this idea of precision medicine and looking at what is actually driving each individual cancer. And in fact, in this study, all the tumors that are involved actually are sequenced so that patients and their providers know what is driving the cancer in that situation. So I'm going to take a little more out of time and talk about alpha-radin, also called Xofigo or radium, which is an intravenous form of what's called alpha particles. So it's different from what we've used before. So many people are very familiar with external beam radiation, which is photons that are given externally from linear accelerators. Alpha radiation is a particle which is actually injected intravenously, and it has a very high energy, and the energy from that particle travels a very short distance. So the idea here is that you can actually give it intravenously. It will go to a part of the bone that is inflamed, because that's what attracts this alpha-radin. And then this is supposed to give you a sense of these being cancer cells, and these sort of darker green particles are the radiation, and they give off energy for a certain distance from where they set up shop. And so the idea is that it leaves more normal bone marrow intact, so less toxic, while killing cells right at the area where it actually localizes. So the drug has been shown to improve survival, quality of life. It involves 6 monthly IV injections. It's actually very, I would say, relatively non-toxic compared to some of the other therapies that we use, and really carries with it a lot of potential for combining with other drugs in the future. So this is supposed to be our landscape at the university and the SCCA right now. So we're talking about adding these new and different drugs in all these different places along the way. We obviously have areas of emphasis here in men who are dealing with resistant cancers beyond what standard of care is already treating pretty well. And we have obviously a lot of drugs and a lot of potential in all of these areas to improve outcomes for these patients. So that's where we're going. So we think that putting all these things together in a way that makes sense is really where we need to be. We're going to continue to work on hormonal therapy because we know it works. And finally, with the help of people like Dr. Nelson and the other folks that you heard from, figuring out how to actually give these drugs to the right people, because we know what's driving their cancers at the right time in their therapy is where we're going to be in the years to come. That's everything I have. Yes. So the next thing that we're going to do, and the final thing on the agenda, is that I've recruited a number of people who actually have participated in clinical research studies. They've been very generous with their time to come up, and actually I'm going to ask them a couple of relatively common questions that we have for folks who are deciding to participate in clinical research and their wives about the process of deciding to participate. They will actually be open to having other questions from the audience after I'm done with my interrogation, and we'll take it from there. So, Mr. Davis and Mr. Goesman, are you folks here? Do you want to come on down and we'll talk just a bit? Do you have the? Can you have that? There's one on the table right there. He may need to So, thank you all again. Again, these folks have been very generous with their time, and they have participated in different research studies along the way. So I'm going to very briefly describe the scenario. So Mr. Goesman was involved in a research study where we combined experimental therapy with radiation for treatment of his prostate cancer in the prostate. Mr. Davis participates, and they both continue to participate in research related to therapy for prostate cancer that wasn't responding to standard hormonal therapy, and so we had him involved in a clinical research study for that. So I'm going to start off the questions asking a very general question of each of you. And I think it's the one that I think most people have about clinical research. So what was the most important thing for you in terms of deciding to participate in a clinical research study? So do you want to go ahead? Yes, sure.
I was a fan of adjunctive therapies, and so I was looking for an edge on my cancer, and so that it convinced me to go that way.
Mine was kind of a two-pronged thing. I was interested in the cutting-edge stuff that goes on here at the University of Washington and Fred Hutchinson. Also there was a chance that I could live a little longer, and then also too, it was a way to give back to the hospital for taking care of me, and also for the people who've gone before me, because a lot of them had, sacrificed their lives or whatever for the treatments that I have undergone. That's pretty much it.
And for the wives, you obviously are part of that whole conversation at the very beginning. I remember having a conversation with each of you. What were the things that were most important to you in terms of your husband deciding to participate in clinical research?
Well, mine was to just make sure that he was in good hands, for one, and that he was responding to the treatment. I had concerns about that, him responding to the treatment, and of course the side effects. But we researched it, and he wanted to give to the clinical trials also, so I just supported him in that.
I saw it as a great opportunity for him to be under very close scrutiny. We travel from Kennewick, Washington, every 4 weeks, so round trip about 450 miles, but it's worth it because he's under close watch, lots of tests, lots of examinations, but it's worth it.
So the other thing, which again, you've been through the experience, a lot of people we're all observing from the outside. Are there things that you think it's important for the folks that haven't participated in research to know? Meaning, I know you've already told us the important things that you had on your mind when you made the decision, but what was, if there were parts of the research that were difficult, but that you got through, or any other aspect of this that you think really other people need to know before thinking about participating in research? Mr. Goesman.
Well, first of all, I was concerned whether you were giving me a full dose or not. I thought it was the placebo effect, because the side effects were weight gain. That was it for me. So it was pretty easy. It was nice to have all the extra help. I think some of the trial nurses were, the way I described them, would be a pit bull in an alley. And she was at my side the whole time. It was great to have all, the extra support there.
I think, too, that you'll hear a lot of warnings about a lot of the side effects of some of the drugs I have taken and you have taken. But you have to realize that these side effects occur, but it occurs in a very small portion of the people who take these. So it wasn't even a thought to me that, yeah, I may have hot flashes, I may have diarrhea, I may have other things, but it's important to try these things. I think it was just very important that I try these drugs, and I think for anybody else who is at a position where their treatments aren't working, is that they should do this. They're all mostly open studies, and the results for me have been excellent. I have been fortunate in being asymptomatic most of the time, and I haven't had any bad side effects or any side effects from any drugs that I've taken.
So any questions from the folks in the audience? Yeah, so I think what Mr. Davis was referring to, so it sort of corresponds to that.
Just have Bruce repeat it, yeah.
So the question was, what did Mr. Davis mean by open? So when we were talking about phases of research, phase 1 through 4, so many of the studies that we do here, not all of them, but many of them are what's called phase 2, where you know what you're getting, and everybody gets that therapy, so there's no question. And so Mr. Davis knew what he was getting, so did Mr. Goesman. And so the idea is it was open in that we all knew what folks were getting, and there wasn't any question.
Kind of a backup question, stepping back from that, but do you approach patients and say you would be a good candidate for this study, or do they need to come to you and say, I'm ready?
Yeah, so the question was, how do we really engage in that conversation about research and whether it's the right thing to do? So I think different physicians take a different approach to this with every individual. I think, what I personally do, and actually the other physicians can comment on what they do, is that I think at each stage where we're talking about doing something different, in terms of therapy, it's an opportunity to have that conversation. And, I usually start by just saying, does this sound at all interesting to you in terms of going outside of the standard of care? That's the first step. And then some people, for all sorts of good reasons are not interested, and that's absolutely fine. But depending on their level of interest, we'll then, engage in a much more detailed conversation at that point. Any other folks want to talk about their approach to this?
No, I agree entirely. I mean, I'm always thinking, mostly because of what most of us do every day and what distinguishes perhaps the University of Washington and Fred Hutchinson from how patients can be very well treated in the community, is being able to try new things. And so I'm always thinking, first and foremost, is there something that I think this individual would benefit from that they couldn't already get, elsewhere? And then start to have that discussion, but it's clearly not for everyone. I mean, there is, risk involved with any clinical trial of a new agent where we don't understand how it's going to perform or behave. But I think, as Dr. Montgomery mentioned, the drugs that we currently have changed standard of care, have shown survival advantage, were first tested in a phase 1. You know, the first time that drug was used in patients, you could see effects, but not all drugs are like that. So you have to go in with really an informed consent, and that takes time, you know, to walk through that process with patients.
Yes.
Thanks, Paul.
Pardon me. Yes, sir.
My question to Mr. Davis was about the symptom of hot flushes. In my case, I'm on hormonal therapy, and my wife next to me, who's a caregiver, suggested that maybe I should jot down how many hot flushes I get and how long, which I did one time.